Okay, so today we'll be talking about respiratory bronchiolitis associated with interstitial lung disease as well as desquamative interstitial pneumonia. As a quick introduction over here, those two diseases are part of the diffuse parenchymal lung disease, which is divided into four subgroups. One of them is the idiopathic interstitial pneumonia. That's divided into multiple groups. One of them is the smoking-related group, which contains the both topics we will be talking today and discussing, which are the respiratory bronchiolitis as well as the desquamative interstitial pneumonia. As a definition, respiratory bronchiolitis, this one is also called the smoker's bronchiolitis. It's not associated with interstitial lung disease. We would see it in smokers who are asymptomatic, and if we get a pathological slide for those patients, we would notice that they have a tan pigmented macrophages in the respiratory bronchioles. However, if the disease advances, we'll get respiratory bronchiolitis associated with interstitial lung disease. Again, this disease happens in smokers, but this time they are symptomatic. They would have cough. Usually it's a chronic cough, more than 6 to 8 weeks, dry cough, as well as shortness of breath. The findings on pathological slides are same thing like the respiratory bronchiolitis, which are the tan pigmented macrophages in the bronchioles. Later on, we'll talk about the desquamative interstitial pneumonia. This disease is considered to be a progression of the RB-ILD, as the pathological slides for this disease would show macrophages that are located at the distal air spaces in the alveoli, but they would present in a similar presentation, which is a chronic cough more than 6 to 8 weeks with a shortness of breath. Epidemiology, it usually occurs in the 4th and 5th decades of life, and smokers usually are exposed to more than 30 pack years of cigarette smoking. Regarding the epidemiological data, it's very limited on this topic. However, most of the studies I looked at, they would combine the RB-ILD as well as the DIP and calculate the relative frequency of both diseases within the interstitial lung disease, and specifically talking within the IIP, which is the interstitial idiopathic pneumonia. In several of those studies, it showed that the percentage of both diseases somewhere between 10% and 17%. The pathogenesis, obviously, it's smoking. In one of the studies that was based on biopsy, it showed the differences between an asymptomatic smokers in comparison to never smokers, and the outcome for the study showed the response of the inflammatory cells in a comparison to the structural changes that would happen on both groups of the study. So again, here the background, basically we're going to look at the inflammatory cells as well as the structural changes in both the asymptomatic smokers as well as the non-smokers. Looking over here, both groups, the asymptomatic smokers, it had 29 subjects. The never smokers were 16 subjects. Both groups had similar age, which is 61 to 62 years old, and they were all men. The PFTs were normal for those two groups. The methods for the study, it was done with a bronchial biopsy, and those biopsies were stained with monoclonal antibodies, different type of antibodies which will identify the neutrophils, eosinophils, mast cells, as well as the macrophages. They were also stained with another type of monoclonal antibodies that would identify the interleukin-1 and interleukin-8. Also, we took a look at the structural changes that happened with those two groups, looking at the epithelial layer as well as the laminal layer. The results for the study showed that the inflammatory cells and the cytokines increased within the smokers group, the thickness of the lamina increased, and the integrity of the epithelial layer has reduced significantly. Here in this graph, we can see 6 different graphs which reflects each one of the monoclonal antibodies. And in each one of them, there's a comparison between the asymptomatic smokers as well as the never smokers. Obviously, we can see within the 6 groups that there was more response within the asymptomatic smokers. And those all changes were statistically significant, as the p-value was less than 0.005. Looking here at the histological studies, in a comparison between asymptomatic smokers and the non-smokers, we can see structural changes within the asymptomatic smokers as the epithelial layer has lost the integrity of it, and the laminar layer has increased thickness. This all happens because of the inflammatory cells, where once the inflammatory cells accumulate in the lamina, the thickness of it would increase, and once they accumulate in the epithelium, the integrity of it will be lost. So as a conclusion, smoking would increase the inflammatory response within those patients who, as well as the pathological findings will be different. In a different study that showed that the smoke extract stimulates the lung fibroblasts. In this study, basically they took the human fetal lung fibroblast and they were exposed to smoke extract, and it showed that there was a significant response with the increase of the neutrophil and the monocyte chemotactic activities, which again proves the previous study, and that's another evidence that smoking would increase the inflammatory response. In a different study also, it showed that the inflammatory response depends on the dose of the smoking. So over here there were 2 groups, non-smokers, again smokers, and it showed that there's an inflammatory response. However, the smoking group was divided into 3 subgroups. The first one was smoking less than a pack per day. The other group was smoking 1 pack per day. The third group was smoking more than 1 pack per day. And it showed the more you smoke, the more inflammatory response you would have. Again, this supports the fact that smoking would increase the inflammatory response. Here are a few radiographs for both the RB-ILD and the DIP. So getting a chest x-ray could be either normal or such as this one over here. We can see it's a PA chest x-ray. Looking at the lower zones, we can see the reticulonodular pattern in both lungs. This is a high-resolution CT scan for 2 types of patients, one with RB-ILD as well as DIP. In the RB-ILD, we can tell that there are mosaic pattern with ground glass opacity. However, once the disease advances and it's considered the DIP to be an extension of the RB-ILD, we can see more severe changes such as cystic changes. That was quick. Any questions for this part?
Didn't mention anything about non-smoking related causes of DIP, like occupational exposure. Did you come across anything in that regard?
DIP. So most of what the studies I found are regarding the smoking, and those 2 diseases are usually have certain, like when looking at the graph, they are considered to be smoking related. I don't know about the environmental studies.
Yeah, there are studies out there, small case series and things of certain industries, especially the important in this area. I was actually involved recently in one big litigation case, a guy trying to get workman's comp that never smoked, that had DIP, was also working with aluminum oxide. Some of the metals, heavy metals in particular, they're oxidized, can cause DIP, and that is documented. You can find that in the textbooks. So it's something not to overlook, even the non-smokers on occasion.
Yeah, go ahead.
What do you say, sorry? What do you usually see on that?
So on the left slide for the RB-ILD, we can see ground glass opacities as well as mosaicism. This one is in the RB-ILD, as well as you can see it, the same thing in the DIP. However, the more severe the changes are, you can see cystic changes. But basic diagnosis needs to have biopsy, because the macrophages with the RB-ILD will be within the bronchioles. However, in the DIP, it will be within the alveoli. Any other questions?
What's the prognosis of recovery?
So regarding the management and the prognosis, Dr. Al-Faqih will tell us more about it.